Hi, I'm Daniel, and this is going to be the intubation competency. So for intubation, the first thing that I would want to do is evaluate the need for intubation. So there would be a few different reasons why to intubate somebody. So an elective surgery would be one. So if the patient's going to be sedated and getting something like a heart surgery or something like that, then that would be a reason to intubate because the drive to breathe is going to be cut off from the sedation. Respiratory failure, so a few causes of that would be something like an acute on chronic COPD exacerbation, a really bad one. Airway trauma, neuromuscular disorders, things like that. Combativeness, so I've seen combative patients be sedated to the point where they needed to be extubated. So those are a few reasons. The second thing we would want to do, in this case, the patient is going to be getting an elective surgery so that I can explain the process of intubation to them. The second thing we would want to do is we would want to check the patient's past medical record for any other intubations in their past. So what we would be checking for is things like, were they a difficult intubation? How many attempts did it take? Were they a difficult wean? So to come off of like a ventilator, how hard was it? What size tube were they? Where was it placed? Just things like that. So next is we would gather our equipment. So what we would be grabbing is we would be grabbing our blade and our handle. We would be grabbing our tube and stylet. Stylet is already in, so that's gonna give us like some leverage to put the tube in. We would be grabbing capnograph, so that's gonna let us know if we're in the airway. We're gonna be grabbing a syringe to fill the cuff. We're gonna have a securing device, so we could use a tie or we could use tape. We're gonna need a bite block also, humidity source. So this is an HME. In other situations, we could be using heated humidity. So we're gonna have suction also. So right here we have our inline suction, but we also have our yonker set up over here. Lube, so we're gonna have lube, forceps, and a bougie just in case it's a difficult airway. And I think that's pretty much it for that. So we also have a manometer, so that way we can actually check the number of the pressure. And we also have gauze for the corners of the mouths, so that way they don't get any sores or anything if we're using, say, a tie. So next we would also want to check our devices. So we have our bag. So we would do our check with the bag, so we're gonna make sure that it can self-inflate. We're gonna make sure that there's no leaks. And we're gonna check the valves, so you can see the valves opening if it checks out. After that, we're gonna check the light source. So the light source works. We would check our suction. So our suction pressure, we would want it 100 to 120. And we could also check the cuffs because most likely we would know what size tube we're going to be using in the patient, so we could already have our tube ready. So we could put some air into the cuff and make sure that it holds pressure. And that's pretty much it for our checks. So the next thing that we're going to do is we are going to wash our hands, and we are going to enter the patient's room, and I'm going to introduce myself to the patient and explain the procedure to him. So, hello patient, my name is Daniel. I'm from respiratory. Can I have your first and last name and date of birth, please? And can I see your bracelet, please? So we would get our patient identifiers. So next I would explain. So what we're going to be doing today is you're having heart surgery. So we're going to be sedating you. So when we sedate you, that's gonna cut out your drive to breathe. So we're gonna be intubating you. So what that is we're gonna be placing a tube into your airway, and we're gonna be placing you on a mechanical ventilator, and the ventilator is gonna be doing the work of breathing for you since you won't be able to do it yourself. There are some complications on the way in. We do use like a metal blade, so that could possibly hit your teeth. There could be some cracking or some lost teeth. It's happened in the past, not here. There also could be too high of tidal volumes on the ventilator, so there could be possible barotrauma, volutrauma. So what that is we could over distend your lungs, and there could be some damage that's caused by that. There could be some irritation in your throat, so there could be some edema or anything like that if the cuff is overinflated. And if you were to be, you shouldn't be on the ventilator for that long because, you know, you're just getting an elective surgery. But if for people who are on there for longer periods of time, they are at risk for things like ventilator-assisted pneumonia and other bacterial infections. That's pretty much it. So do you understand what we're going to be doing today? Patient would confirm. If the family was there, I would get some confirmation from the family as well. And then we could actually begin our procedure. So what we would do is we could place a towel maybe under the patient's shoulders if we had to, but we want to get the patient's head back so that way they're in a better position for us to get a blade in and actually intubate. So right now my partner is hyperoxygenating. We would be at 100% oxygen. We would just max this out. He would be hyperoxygenating. Right now I would again do another check. So I would check to make sure my light source is ready. I would lube up my cuff, my tube, so that way it's easier to get into the patient's throat. When I take my attempt, I'm not going to want to take any longer than 30 seconds. So I will count down with my partner and I will let him know when I'm going to go. And if it takes any longer than 30 seconds, I'm going to come back out and he's going to hyperoxygenate all over again. So when I do this, I want to hold the handle in my left hand and I'm going to want to insert the tube with the right. I'm going to be going in from the right side and coming to the left to kind of displace the tongue. And it's coming up here to where I'm going to do my attempt. So I would let my partner know. All right. Oh, another thing that you can do is you can angle the tube kind of like a hockey stick, so that way it's easier to go in to the airway, because if it's straight, it's going to be very difficult to get it in there. So you want to angle it kind of like a hockey stick, so that way when you go in, it just kind of goes like at that angle to get in. So I let my partner know. We're ready in 3, 2, 1. So I would place the blade in, put the tube in, come out with this, style that out. That is inflated. He's going to secure the tube. We're looking for gold on the capnograph. I'm going to listen to lung sounds. So I listen to lung sounds. I can hear equal aeration on the left and right side. I could also listen to the stomach and make sure I don't hear any aeration going into the stomach. Once that is done, and once we're sure that we're in the airway, what we're going to be doing is we're going to be securing the tube. So I'm going to be using a tie. So can you come up for me, please? Thank you. These gloves are too big. Now we come around the neck. And we want to make sure that we keep the cuff and balloon away. We don't want to tie those up. So now the airway should be secure. After the airway is secure, what we want to do is we want to place our bite block. So I'm not going to actually stick it, but we would place our bite block, and we would take this off.
Back it up in 3, 2, 1. Take that colorimeter out.
So now we could also take it off the bag, and we could place the patient on the vent. We have the suction inserted, we have the humidity inserted. Again, if it wasn't an HME, we could be using something like a heated wire circuit, and that would pretty much be that. So after that's done and the patient is on the vent, things that we could do is we could order a chest x-ray to confirm tube placement. Again, we would want to make sure that it's 2 to 3 centimeters away from the carina. We would also be checking the pressure on the cuff. So again, we would want it about 25 to 30. So right there would be about good. There are 2 other ways to test the cuff pressure and to make sure that it's adequate. With our stethoscopes, listening to the airway, we could take air out while it's inflated and there's no leak. We could take air out slowly until we just barely hear a leak, and that would be the minimal leak technique. And then the other way that we could do it is when you do hear that leak, you could put air in slowly until the leak is no longer audible, and that would be the minimal occluding technique. After that, I would monitor things like his vitals, so heart rate, respiratory rate, blood pressure, saturations. I would listen again to lung sounds, make sure that I'm getting equal aeration. After that, I could bring in like a whiteboard or a chalkboard, so that way when the patient wakes up, they would have a form of communication. Once that's all done, I would take my gloves off, dispose of them in the trash, wash my hands, and I would go out and I would chart. So things that I would be charting, again, would be like the vitals, so the blood pressure, respiratory rate, heart rate, lung sounds. I would also be documenting how many attempts did it take, so that would let anyone know if it's a difficult intubation. I would also be charting tube size, tube placement. For women, normally they're about a size 7.5. For men, they're usually a size 8. Sizes that I typically see used are 3, and I also usually see the Mac blade used. So the difference between the Mac and Miller is the Mac goes into the vallecula and displaces the epiglottis indirectly, while the Miller, the straight one, goes into the epiglottis and lifts it directly. The maximum time that I would want to be away from oxygenating, so again, each attempt that I would take no longer than 30 seconds. If there was an esophageal intubation, one of the ways that you would be able to tell is when you're listening to the stomach, you would hear aeration in the stomach, and also on the capnograph. This might not turn gold because there would be no CO2 return. Also, again, to tell that you're in the chest, you would see chest rise. You would hear aeration on the left and right. If you heard aeration on the right but not on the left, you might have like a right main stem intubation because of the angle of the right stem. So what you would do there is maybe take out or withdraw maybe 2 or 3 centimeters. On the chest x-ray, once we get it, what we would want to see is we would want to see the tip of the tube about 2 to 3 centimeters away from the carina. And complications of intubation, I named them to the patient, but to go over them again, on the way in, what you could do is you could hit the teeth, so you could possibly crack teeth. You could knock out teeth. Working its way down the throat, you could have maybe some edema or some airway irritation in here from the cuff being having too much pressure inside of it and going further down. Again, with tidal volumes that are too high, you could possibly have damage to the lung because it's being filled with too much air, so things like pneumothorax are possible. And again, being on there prolonged periods of time, they're at risk for things like ventilator-assisted pneumonia and other bacterial